as I was saying, to think of a person versus a diagnosis, to think of the pictures that were seen before. The little smiley face is much easier than to see the complex chart that I showed you, because that is overwhelming. And if I didn't know anything about special needs, I would be running for the hills. If I was like, there's no way, there's no way. But he's a person, and that's how we need to approach every situation. And so I was very brave to show my picture of when I had Devin. And I did not realize this picture existed until a few years ago, and someone sent it to me. And now that I know so much medically, my concern was, oh my gosh, he's jaundiced. So that was my first connection. Then I took a real nice glance at myself, and I'm like, well, that's not me. But yes, that's me. So we have had 2 decades worth of medical encounters, and the other picture is him graduating from high school at 19 years old in 2015. So 2 decades full of medical encounters and enough experience to, I wouldn't even know. So we can go to the next slide. And actually, can we go back one? Because I want to touch on this people first language just a little more. I don't know if we can go back. And I want to put this into perspective because language is so important. And it may not feel like it's that important, but it is, especially within this population. And this will kind of give you a real life example. So if we think of our daily interactions and how we introduce people, and think of the language you use. You introduce people by their first name. You focus on them as a person. You don't hear people saying, yes, okay, so this, the bald-headed diabetic to my left is so-and-so. We don't do that. But for this population, for some reason, it's common to do that. We don't talk about people by their identity, by their disability, by their diagnosis, or by any kind of a trait or feature. Like, I apologize for any bald people with diabetes, but we would never introduce you as that. What we do with kids with special needs, for some reason, it's common, and it's to say the autistic kid. So if you just kind of think about it in that way, that we wouldn't do that with anyone else, and we shouldn't do that with this population. There's certain words that I really, it's almost sad that I have to mention it, but that are just not okay to use. And this has happened to me numerous times, even in an EMS emergency situation, where kind of the first thing that comes out of their mouth is, how retarded is he? It's those things that one sentence, it's crushing. And so you don't need to use those language. I've heard language as broken. I've heard everything you could possibly say. And it's just not okay. And just think about how you approach and how you introduce and how you talk about other people in your life, and you don't necessarily do that. So then it's not okay to do that here. And I hope that you can take away that from this presentation it is so important to really think of the person first. It's the child with autism, or it's the child with Down syndrome, because they are more than a diagnosis. Okay, we'll go to the next slide.
Okay, so Melissa's going to sign off for a moment. Oops, there we go. And I'm going to move forward, and let me see if I can get my screen video working. Anyway, we're going to be talking about the variety of children that have special health care needs, children and youth. And it's very hard to get them into categories. One way, there are a couple ways of thinking about it. One is congenital versus acquired. So we'll talk a little bit about that. There are also the life-threatening abnormalities or malformations that can happen. And then also the things that are very physical that you see right off the bat. And then behavioral and sensory malformations or disorders. So we're going to kind of touch on each of those and talk a little bit about the variety and the percentage of those kids. And so if we think about congenital versus acquired, the first thing that comes to mind for congenital malformations is usually heart malformations. This is one of the most common, very drastic malformations that happen with kids, mainly because it oftentimes needs to be addressed right away at birth. And so we worry about that. Another congenital is seen right away are facial malformations like cleft lip and cleft palate. But then the syndromes and genetic abnormalities often come to light later in the evaluation of the child. And we'll talk about those a little bit more. Oh my, we just lost our light in here. Let me see if we can fix that in just a second. I'll kind of be a ghost for a moment. Yeah, there we go. Sorry about that. We're in a building that has nobody else in it but us. And so I think it kind of decided we had gone to sleep. Then we'll talk also about neural tube defects, developmental delay, immune deficiencies, and autism. And those are all considered more congenital, while the acquired ones include traumatic injuries, psychological, in essence, injuries, diabetes. And diabetes, asthma, behavioral, and food have genetic tendencies. So sometimes diabetes or asthma will run in a family, but they don't necessarily come to light with every child. So it's more of an acquired system. So we'll talk a little bit about that, about the different varieties of children with complex disorders. As I said, cardiac is one of the most common. The incidence is about 7 to 10 per 1,000 live births. And it may be something that presents right at birth, or it may be something that presents later on in life, like as a failure to thrive diagnosis. One way to divide these up are cyanotic versus acyanotic. And some of the cyanotic malformations are tetralogy of Fallot, truncus arteriosus, total anomalous venous return, and single ventricle. On the right, it's showing a patent ductus arteriosus, and that is oftentimes acyanotic. In other words, the patient can continue being a little bit pink, but it oftentimes will cause failure to thrive. The single ventricle usually is something that has to be addressed right at birth because it is not compatible with life, and oftentimes those kids have to go to surgery right away. The VSD is a very common disorder where that's a hole between the ventricles, and that can cause mixing of the oxygenated and deoxygenated blood. And in those situations, those kids can oftentimes wait until they're about a year of age before they repair them if it's not too large. And so, so these again have varieties in them. They do have a lot of complications that you as an EMS provider or a ER provider would have to be aware of. And the most common problem with a kid with cardiac malformations is that they might be hypoxic or have hypotension. And you'll have to deal with that. One important thing, and I think Melissa will touch on this later, is that knowing how much oxygen the child exists on is very important. So in other words, if the child has a malformation where there's a lot of mixing of the oxygenated and deoxygenated blood, they may have a resting oxygenation percentage of about 85 or 80. And with most of us, that would cause severe distress, but those children have adapted to it. And that's often the best that they can do at that time. They also are on all sorts of antiarrhythmics at times or anticoagulants. And so being aware of that when you're dealing with a patient like that is important. This little baby below has had open heart surgery, and that's where you see that, that scar down the center. And as I said, many of the disorders have to be treated right at birth. Another one that is noted right at birth is congenital neurological problems like meningomyelocele or hydrocephalus. Meningomyelocele, also known as spina bifida, is where there's an opening in the back by the spine, and nerve threads are allowed to come out through that. Sometimes it's very subtle, like just a sacral dimple, but sometimes it's very pronounced, like the drawing of this baby. And oftentimes these kids will have hydrocephalus, which is an increased fluid and pressure in the brain ventricles. And these kids will often need to be treated right away with a ventricular peritoneal shunt or some similar shunt. If caught early enough, usually these kids do okay and don't have any developmental delay or mental disorder, but oftentimes they do have a little bit of developmental delay. We also talked about syndromes, and the most common viable syndrome that is around is Down syndrome. That's trisomy 21, and as Melissa referred to her son's karyotype, this is a situation where there are 3 21 chromosomes. It's 1 in every 750 live births on average. And again, even though it says that there's developmental delay, some of these children are very high functioning and do very well. So be aware that not to clump all Down children in the same basket. Some of them are very high functioning. They also have a tendency to have cardiac abnormalities, and so they often have had cardiac surgery early in life. And then they also have C-spine injuries. This is where these children will have a little bit of a sliding or ability to dislocate their cervical spines. And so children who have Down syndrome should be checked out before they're allowed to do certain sports, especially gymnastics and certain like football, because it causes pressure on the spine. And it's kind of funny, but the children who have Down are often failure to thrive as an infant and end up with a G-tube. There are other congenital abnormalities, errors of metabolism. The one thing about the inborn errors of metabolism is that the newborn screening that is done in each state usually checks for a lot of these. That includes galactosemia and also things like sickle cell and some of the other inborn errors of metabolism. And the important thing to know about your newborn screen is sometimes we'll have children who are home births, and to make sure that the child gets a newborn screen early in their life, preferably within the first couple days of life, so that they can make sure that they don't have a error in the metabolism that can be treated with, usually with food and dietary supplements. Then there are also congenital anomalies of the blood work, and that is most markedly hemophilia and sickle cell anemia. Hemophilia is usually congenital, and it's usually X-linked. There are a few similar type blood disorders that are like hemophilia that are not necessarily X-linked, but on a whole, they are the X-linked, lacking in factor usually 7 or 8. And what happens is they're easy to bleed and easy to cause bruising. Our biggest risk with those children is intracranial bleeds. And then sickle cell anemia, this is autosomal, so it affects both boys and girls, and it is, again, inherited. It's usually found in the Mediterranean and the African heritage children, and we're losing my lights again here. And these children can have severe pain crises and can also have silent strokes and may need blood transfusions. This is where the red blood cells are sickling when they get into certain pH levels. And then other acquired things are when the child is fine and then develops other problems. Cardiac arrhythmias is one of them. Supraventricular tachycardia and AV block can develop later in life. And then cancers. And cancers develop a whole new crew of special healthcare needs. These children could have blood cancers like leukemia, or solid organ cancers like Wilms, neuroblastoma, or brain tumors, or bone cancer like osteosarcoma. There are many more, but those are the most common. And the deal with these kids is that they usually are treated with chemotherapy that causes immune deficiency, and many of them need to have a shunt, and so they're very, very susceptible to infections. And so if a child with cancer has a fever, that's a medical emergency, and bringing them in to be evaluated and probably get antibiotics is the most important thing. Other acquired abnormalities, we're just going to touch on asthma and diabetes, even though these are very common, but these are some of the things that we see all the time. And these children need to hang on to their inhalers and be ready to use them when they need them. And the insulin-dependent diabetics need their insulin and pumps. We'll talk a little bit about pumps. And food allergy children also fit into that, children with special healthcare needs, needing to have an EpiPen handy. Then another category way of handling this is looking at life-threatening. And so some congenital heart malformations, like hypoplastic left heart syndrome, needs immediate surgery at birth. Tracheoesophageal fistulas that cause blockage of the esophagus also need an early surgical remedy to this. Some metabolic disorders like Niemann-Pick both need early treatment, but can also possibly end up terminal. And then congenital adrenal hyperplasia is another one that is a worrisome situation, usually develops somewhat later in life, can be inborn. That's where the patient is missing a specific enzyme that causes the steroid cascade that gets you into cortisol, your stress steroids, where they aren't making them. So that's that green enzyme there, the 20-to-1 hydroxylase is not functional, and consequently they don't make cortisol, which is what you use to help you get out of all sorts of infection type stress situations. And usually diagnosed by newborn screening, but can be acquired later if depending on injury to the adrenals. And usually they need a daily replacement of oral hormones and then ready replacement of stress hormones if they get into trouble. And EMS providers might need to know about this because at times these people will go into shock if they're not given the corticosteroid medication that they need. Usually the family will have it in their go bags, and we'll talk more about go bags in a little bit later. But it is something to be aware of and to anticipate, because if an adrenal crisis starts, they need to get that, that steroid right away, or else they could end up in shock and die. These children are treated usually with Solicortif, and the parents usually have the medicine or it's in their pack. There are numerous different legislations that have been talked about helping these kids so that they can get their medication, and knowing about your own state's rules and laws is a good way to be ready for these children. And then physical also plays into a role. These are the kids that you look at and say, oh yeah, there's something wrong, what's going on? We talked about spina bifida in the neural tube thing, but cerebral palsy is an inherited, well actually more of a delivery disorder that happens right at birth. It's usually some sort of insult in utero that causes cerebral palsy. And then osteogenesis imperfecta is a inherited problem. And then traumatic injuries happen just by having not, getting into an accident and not being lucky. We'll just touch on cerebral palsy. It's the most common that we see in musculoskeletal. Wide variety of kids, some very mild, some very severe. Some kids just have maybe a foot drop or so. May have developmental delay or may not have any developmental delay at all. And so it's a wide range again. And then osteogenesis imperfecta is the situation where you have brittle bones and limited mobility. And then finally, acquired neurotrauma or acquired trauma chronic problems. Probably the most devastating is the neurotrauma causing brain injuries or paralysis. The young man below there is Jack Yablonsky, and he was a hockey player in Minnesota in 2011, and he got checked into the wall and ended up with a severe C-spine injury. The most wonderful thing about him is he's had lots of work, and he's gone through so much rehab, and he has been able to go to college. He went to college out in California, and he is now, last I heard about it, he was working for the hockey team, the Kings, out in California as in their administration area. And so he's still working with hockey. But it just shows that if you work hard and are lucky and have the right situations, they can overcome a lot. But he's a quadriplegic, and he's able to get around in his motorized wheelchair and be very functional. We're just going to touch on the sensory impairments, just because that's a whole nother group of kids. Visual impairment, hearing impairment, taste impairment, which can get you into trouble if something is tasting off or spoiled. Tactile impairment. I'm sure you've seen some of the kids who don't have very good tactile sensation, and so they've actually caused eye damage by rubbing their eyes. Proprioception impairment, where children are very clumsy and falling into things and cause a lot of trauma. And then hyper and hyposensitivity. And that kind of comes into our next area, which is more in the behavioral and psychological. I'm going to let Melissa talk more on the autism spectrum range of it, but it's called a spectrum for a reason, because it is such a variety of children with that. So Melissa, do you want to add in a little bit on this?
Nope, we can go into the next slide so I can do my story. It's just gonna to bring to light this.
Okay.
Thank you. And then a couple of other tips from the information that you went through just now is, if you can think of somebody that has a physical disability, and it may be something, you just kind of put 2 and 2 together, and for some reason you just assume a developmental disability. But what I can tell you and kind of give you this tip is to, in any of those situations, always presume that they have typical neural development. Always assume that until you know otherwise. There's plenty of situations where people are spoken to or spoken down to and things because of that assumption. So if you can just always assume that they, typical neural function, and then until you know otherwise. So going back to the behavior issue, and now I'm going to go through this story and see, you guys can kind of follow along and see, okay, what would you do if this was, if this came to you, or if this was a call that you took? Kind of work it along with me just to kind of see, maybe you do this or that. And so kind of get your thoughts going on this. So I picked Devin up from school. This was middle school age. And the nurse was just concerned. She said, he's having a lot of self-injurious behavior. We're unable to distract him. We're unable to redirect him. This is highly unusual. And remember, he has pretty severe autism, and he also has developmental disabilities. And there is this connection of, well, they have behavior problems. And so it's almost kind of written off, like, oh, that's just a behavior problem. But I encourage you to look to their behaviors is a way of communicating. It's a way of showing frustration, especially if they're nonverbal. So I challenge you to always look beyond that, especially if they do have a history with behaviors, but this is out of the norm. So what is it? What is he trying to say? What is he trying to communicate? Because if you think about in your own lives, and if you were unable to communicate, and if you were upset, how do you respond? Okay, you can yell, you can, you're in rush hour traffic, you got your horn to honk, you have all these different things. So think of it in that way. Is it that if you couldn't talk and if you were frustrated and you need to get your point across, how would you do it? So, so we present to the ED because I don't know, this is highly unusual for him. Triage nurse right away reviews a record and says, okay, severe developmental delay and autism. We were escorted immediately to a mental health room. And then an EMT arrived and stayed with us. And so I said, I don't think this isn't a mental health issue. I'm really concerned, like something is wrong, because he does have behavior issues, but we manage those. We have techniques and we have redistraction. We just have all these different things. And this is just out of the norm. And so I stated this, and if there's any special needs parents on the call, bear with me where you're repeating it. And you're like, no, 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 something's wrong, something's wrong. We really just want someone to take our concern. And so my son was calm for a good 2 hours. So doctor says, I think you could go home. Whatever it was, he seems to be over it. So I'm like, okay. We can go to the next slide. So now we're home. He's calm throughout the evening. And then in the morning, early morning, these behaviors came out again. And I'm like, I just have never seen him like this. And so I called a neurologist and I said, I know that he has some neural conditions, but they're asymptomatic. There really isn't this over concern that I'm worried about. And he goes, okay, yeah, let's try to figure this out. I agree, something's probably going on. So he's like, I can get you in for an MRI on the same day. So now, what do we find out? What are the results? Massive brain aneurysm in the left carotid artery and an immediate admission to the PICU. And if you could click on again, Paula? Yeah. Nope, sorry, the other one. So this is what I want you to think about. And you're not going to know all of the answers, and no one is expecting you to know everything. I did not know what was going on. A lot of people didn't know what was going on. But could you just assume what you know and say, okay, developmental disabilities, behavioral conditions, and that's it? Or there's another road that you can take, and you can go, hey, okay, let's really think about this. This is an individual child, atypical for him. Let's look further. And I know that in your situation, especially emergency medicine, it's like quick. Everything is quick. What do we do? What do we solve for right now? But I just want to challenge you to go, okay, let's think. And this is, granted, probably worst case scenario, but if you just took a minute and say, okay, I have these conditions and what I know about these conditions, and that is so important to know, have some sort of a knowledge base, but then to actually go a step further and say, okay, if this is unusual, what else can we do to figure this out? And I think that leaves us for our break time.
Right. So we're going to have about a 5-minute break. So I'll go ahead and put the stopwatch on, and we'll break for about 5 minutes. Take it easy. So we have about 2 minutes to go.
Any water or anything?
So we have about 1 more minute to go. Go ahead and pick up your beverage and come on back, settle in. This one will be a little bit of a shorter segment, and then we will move forward and have another break just before the final segment. So you can kind of gauge yourself on that. And then as our EMSC managers are gathering the questions and organizing so we can talk about it at the end of the demonstration. So in about 30 seconds or so, we'll start back in. All right, that's been about 5 minutes. So we're gonna get back into the next segment. And as I said early on, or during that break, we're gonna have another segment of talking and anecdotes and polling, and then we're gonna have another break before we finish the final group. So you can kind of gauge yourself that way. So if I can try to figure out the polling thing again, we've got poll question number 5. So poll question number 5 is, have you ever struggled with dealing with a child or youth with special healthcare needs, either by interaction, diagnosis, or treatment? And so go ahead and choose yes or no, and we'll go ahead and give you about 10 seconds for this. All right, we're about at 10 seconds, so I'm going to end the polling and share the results. And so yes, majority, 70% of you guys have dealt with problems related to this. And it's not hard to believe, because that's why you're here, trying to learn more. All right, and so let me stop sharing the results and we'll go on to the next. The next question is, so this one's a little bit of a long question. And what we want to know is kind of why you struggle with these kids. And is it because you're afraid you're going to miss something? Is it because you are afraid you don't know enough? Is it because there are too many things wrong? Is it afraid you don't know how to talk to the parent or family? Or is it because it's going to take too much time? So you can put down as many as you wish. If you think all of those things cause you angst, go ahead and do that. And you get about another 10 seconds here. Okay, we're going to stop the polling right about now and sharing the results. And it is primarily because you're afraid you'll miss something or do something wrong. And then you're afraid that you don't know enough. The other ones are not quite as important, but they do kind of represent something going on. All right. And so as I said, the second half, we're going to talk about how to deal with a child or a youth with special healthcare needs with the parents around, and then without the parents around. Then we're going to do a break and talk about equipment, children and with special healthcare needs during disasters, and red flags. So we'll move along here. So usually the family members or the guardians are with the child, and usually they're trying to tell you what's going on. Now, be aware that these parents, just as Melissa was saying, she says something's wrong with him, but I don't know what. And so it's very important to sit and to try to listen to the family member and try to figure out, or the guardian, what they're telling you and what the problem is. I was telling Melissa earlier that I had a patient that was nonverbal, autistic, and he had been having terrible times with constipation. And we had finally gotten him to go to the bathroom and poop everything out. And he was, because of his constipation, he was refusing to eat. And once he pooped everything out, he was voracious. He ate everything in sight, and suddenly he had severe abdominal pain. And it was like, oh my God, now I've created another problem. And so trying to figure out what direction you're going to go to try to help these kids is important. I know a lot of the worry for the polling question was that you're afraid something bad will happen. And believe me, the guardian and the patient really aren't too worried about if you're afraid. They want you to help them and try to troubleshoot and figure out what's going to happen. One thing is to ask for previous problems. Was it, last time they had a fever, or last time they were throwing up, did they have a urinary tract infection? And patients who are in a wheelchair very often get urinary tract infections. Do a focused exam, so you're looking at the problem that they're worried about, but also don't forget to look everywhere else too. Sometimes you can do your entire exam in a wheelchair with the help of the guardian or the parent, and they can tip him forward, move the child back and stuff like that. But you don't want to miss a bed sore. You don't want to miss a rash. And then practice team, trust every member. So you're going to talk to everybody and trust them and try to work through the problems with that. So Melissa has a good story about trusting.
I want to make you put your thinking caps on again to try to figure this out with me. And I'm doing this way because just to get you to think, because there is no way, not now, not even after this, you hopefully will know a lot more. You're never going to know everything. And that's not even the point, is that you don't have to know everything. It's just a matter of problem solving and trying to figure this out. So walk through this with me, and this is my beautiful little Devin again. So just wouldn't put his foot to the ground. He just wouldn't. He wasn't upset or anything. He just wouldn't put his foot to the ground. I'm looking at his foot, his ankle, I'm looking at everything. There is no visible injuries, not even a red mark. He's nonverbal, so can't ask him. So he's just standing there sort of in a flamingo type thing, and he's just, that's it. I'm like, okay, gotta go to the ER. And so something's wrong. I don't know what it is. So we can go to the next slide. Poor little Devin has a sewing needle in his foot, to the point where the sewing needle, it had gotten so embedded, the skin had grown over, and there wasn't even a red mark. And a lot of children and people that have autism, they might have a different pain level or sensation. Because the first thing that I thought of, if you stepped on a sewing needle, and mind you, the sewing needle was not, and you can see in the picture next to the dime, it's, I'm not a sewer, but it's like the big end that you put the thread through, that's how it got into his foot, that end. So it was like not even a sharp, it was a blunt way it entered. And he actually had walked on it to where it worked all the way up to the bone and actually curved, is how far it been up there. So he had a surgery right away. We got the needle out. And of course, like my darling, if you can just see his face above his foot, I mean, he's smiling. He's like, good, he got the needle out. This is an example of, I have no idea. I don't know. the foot won't go to the ground. And it was a matter of, I'm sorry, what was that?
Yeah, Melissa, did how many x-rays did they take to try to find it?
Just one.
Oh, they didn't do the whole leg?
No, we did one of the foot, and they said, we got it. And I go, you have what? And then she showed it to me and highlighted it. And I'm like, oh my goodness. And she goes, that's a sewing needle. And we're gonna sign up for surgery. So it's usually start at one, and then if we can't figure that out, we go to more. Never a dull moment.
Yes, I have searched for things on children who have been limping, and yeah, they do that flamingo stance where only one leg down, and and kids don't lie. That's the important thing. And neither do kids with special health care needs. They don't lie. They won't walk on their foot if it hurts. So, or they'll walk a little bit, but not as much as usual. So, yeah, you kind of have to do a detective thing. So it's important with these kids is to look at the whole child and read the old charts. One thing that I always stress with the residents who work with us is that you need to look at the vital signs. All pediatricians are very used to seeing the vital sign that they get in triage or in the beginning of the clinic. And it's usually the heart rate is 180 and the respiratory rate is 60 and the blood pressure is can't get. And so it's important to get the real blood pressure and heart rate and respiratory rate when they're calm. And then majority of these kids with special health care needs who are very complex have notebooks which have vital signs every 4 times a day. Compare them. I had a mother come in and she said, I don't know what's up, but his respiratory rate is up 20. He's usually breathes at about 20 and he's now breathing at 40. And he wasn't breathing, he wasn't working hard to breathe, but he was breathing at 40. And we searched around and got x-rays and did find pneumonia. So it's just, trying to figure out what's important. And then if you're a caregiver that's in a clinic or in a ER, don't be afraid to contact the primary caregivers. That's what they're there for. And they do have on-call caregivers for people who may not be around at that time. So being aware of this and calling them, I was also talking to Melissa and saying that I had 2 or 3 patients transferred down for different problems. And when they arrived in my ER, I examined them, called their primary. The primary said, oh, well, we'll just, change the insulin amount and send them home. And they've been transferred down 2 hours from out of town. It's not that difficult to try to get a hold of people. And the other thing on this is that at least in Minnesota, every physician who has a license has to list at least 2 other people who would be on call for them. And so usually there's somebody to follow up with. Now for EMS providers, one of the important things when you're transporting a complex child or just any patient is making sure that you have all the information for them. And one of the things is the go bag. So we're going to talk about what to take with them when you transport them. And I don't know, Melissa, if you want to join in on this. So a go bag is something that you have handy that has everything that you're going to need when you get to the hospital. And one of my pet peeves is making sure that the meds are in their prescription bottles. Lots of people decant their meds into little plastic boxes and, it's the blue pill that I take at noon, but you can't do that with prescriptions. You got to know what it is. So that's an important thing to have with it. What else do you need, Melissa?
So the thing about a go bag is if no one tells you to put a go bag together, you learn from what you missed. So that was the instance for me. And it was actually a wise EMT that gave me this little tip. And he did so probably out of the situation. So my son, one of his conditions is he can't control body temperature. And so a fever of 102 went to 105 rapidly. And of course, 911 calls and got my son in the ambulance and they said, okay, Mom, do you want to grab some things? Do you want to grab your purse? because I will tell you, somewhat of an intelligent person, but in that emergency, and if it's your child, everything you know, everything in your brain just melts. You are not in the right frame of mind at all. So just that simple, do you want to grab your purse or something? Somewhere clicked in my brain to say yes, and I grabbed a bag and just emptied all the contents of Devin's top drawer. What I ended up with was a bag of socks. And this gentleman was like, that's okay, you know, he goes, let's think of some other things that we might want to bring. But he knew what I was afraid of. And you know what I was afraid of? I was afraid that ambulance was going to leave without me. And that was the only thing I thought of. Like, we got to go. Like, they're going to leave without me. I got to get, and he goes, we're waiting for you. And he's in the back and he's fine. He's good. We're not going to leave without you. So replace some of the socks with some other important items that I needed. And one thing that didn't occur to me till later is we had a go bag and it worked great. I had all of Devin's stuff, but I had nothing for me to survive in a hospital for 24 hours. I didn't have a quarter. I didn't have anything to go to a vending machine. I didn't have a phone charger. I didn't have anything. And so that's a little kind of takeaway is what does the parent need, or what does the caregiver need for simple just to survive for 24 hours?
Yeah, and also the place where you're going may have stuff for you, but it certainly will not have your favorite toothbrush. It will not have a brush, and it usually has Johnson's baby shampoo for shampoo. So, so bring what you think you need. Also, if you're transporting the patient and the parents are not going with you, make sure you tell them where you're going. When people are transported to the Twin Cities, there are 3 different children's hospitals they could end up at, or actually 4, and numerous other hospitals. And so if you tell them that you're going to children's, make sure you tell them which children's. It's important that they know. If they're not coming with you, make sure you get a telephone number that you can call, that the hospital can call them back at, and that they are available, because if they're going and the kid needs surgery, they're going to need consent. They will do surgery on a patient emergently, but emergently doesn't always equal, yes, they need surgery. You know, if they're going to have dead gut, yes, they'll go in and do surgery. But if it's something that they could delay on because they don't have your consent, or if it's worrisome, they need to talk to you. They need to talk to the parents. And then, as Melissa was saying, tell the parents to dress for the weather. You know, we're all in the Midwest and the Heartland, and weather changes. I've had someone come in wrapped in a sheet, a parent come in wrapped in a sheet. Now, we can find scrubs for that parent, but you know, it's not going to do very well when the temperature drops to 20 outside. Make sure that they have a car that has gasoline in it, and tell them to fill up with gas. Another thing that I've known over the couple of years is when they're transporting a patient down, if the family can't get it together to come down in the middle of the night, and no one, you know, it's a 3-hour drive and nobody has enough rest to drive the car, tell them to stay home and have the telephone next to them, and then they can come home in the light of day. You know, we don't want a second accident. We don't want people hitting deers. If they don't need to come down with a child initially, that's okay. All right, your turn.
Yes, the one, so far, one and only time Devin had to come by ambulance to the hospital without me. This is the one and only time. And so he was in high school and he's injured at school. And to set the picture, I got a call from the school nurse, and all she said was he fell. And we didn't know for 3 days what happened to him. And as you can see by the x-ray, and you don't need to be a radiologist to see what I see, that is a horrible break. His arm was severely swollen. It was pretty obvious that was a break. His school was 45 minutes away from the hospital, and I'm waiting at the hospital for him. And he arrives at the hospital, and He just looked, the look on his face, it looked like pure shock. And I just said, has he had any pain medication? Has he had anything? And if we think about this when it comes to special needs kids, you might think if I do nothing and I just have to get him there, that way I won't harm him and I won't give medication that maybe he can't have, or maybe I'll have an abnormal reaction. And you just are like, you know, I'm just gonna get him there, right? Because that's the thought process. But I encourage you to think about it a little differently. So he has an atypical reaction to pain. So he's not screaming, he's not crying. His vitals were actually looking really well. And of course, just a mom, right? I look at him and I'm like he's in shock. And I thought, like, okay, that's their job, was to get him here. But for a 45-minute car ride, and we all know car rides, right? Bumpy, everything, and to have that severe of a break, it made me very sad. It almost to a point where it almost felt like inhumane to some extent. And the thought was, why didn't they just call me? Why didn't they call me? Why didn't the ambulance call me and ask about pain medicine and ask about what he can't have, just anything at all? Because I was sad for him. And I was sad for him to the point, and I've done this a lot, and where I just looked at him and I just said, I'm sorry, like, I'm sorry that happened to you. Because I don't think that it should have. I think that even though there's an atypical reaction to pain, it was an apparent, and maybe not so apparent because you don't, but just to kind of get that through your head and say, you know, maybe we're gonna play it on the safe side, and we're just gonna get them there. But also, what are we looking at in terms of suffering or pain or anything like that? And just to have sort of that human side of, would I want to ride in a 45-minute ride in an ambulance with a break like this? And then, you know, the story unraveled from there, and he does have this broken arm, and it was this, you know, we dealt with that and we got that fixed. And so what happened after that was, this is the limping issue. And I was like, well, maybe the limping is, you know, the cast was heavy. Maybe it's something like that. Again, we didn't know what happened to him. There was, you know, actually the EMS was very helpful in that regard, and they didn't let it go. There was reports filed, there was maltreatment of a student, because we needed answers. And so it was this investigation. But at this day, when it was the limping, and we had to go back to his orthopedic doctor. And another thing is, my son also has osteoporosis. So it takes a lot. He doesn't to break something, but it also is a lot easier than maybe some others. Go to the doctor. I said, he's really limping. I just don't get this. And he said, well, the doc's like, I don't think it's anything, like, you know, because he's walking pretty good. He just has a little limp, but to be on the safe side, we will do an x-ray, since we don't know what happened to him. He goes, but go for the x-ray, but just go home. I'll call you if we see anything. Halfway home, of course, I get the phone call, and emergency surgery was needed because he had a broken hip and a broken femur. That was cutting off his femoral artery, close to cutting off a femoral artery. And that just it was like, oh my gosh, you know, that amount of injury. Come to find out later after, you know, police and EMS, really phenomenal job, and not letting it go, really did their due diligence to figure out, this isn't a fall, what happened? So they were able to figure out that my son was standing around a corner in high school, just right in the hallway, and he was just right around the corner, just standing there. The bell rang, and those who know about special education, you know, he had a paraprofessional that was supposed to get him into the next classroom before the bell rang. And then, of course, some big senior kids, you know, came flying around the corner and knocked him into a cement post. The kids couldn't have been more, they felt horrible. They were like, oh my gosh, because it was a complete accident. But my son, got hurt pretty bad by falling into that cement barrier. So yeah, it's just to have these things in mind. And I do see some chats coming up about the ability to give pain medications. And maybe that's a further discussion. Maybe that is an issue that we need to troubleshoot as a whole. I know there's different licensing and different scope of practice. I get that, but it's kind of the patient. So what can we do? And let's think about this. And if that is a barrier, what could be done? What is it? Just to kind of think, like, is there solutions somewhere? Is there maybe basic, maybe EMT wasn't, maybe an advanced ambulance that have transported him? I don't know the answers. I'm a mom. I'm just saying, I'm like, he was in pain and I just felt horrible. So we can go on to the next one. And I think I can probably talk about this one too, about the medical.
Yep.
Sorry, Paula, yeah. Only because there's so many things out there now. So you're gonna be looking for medical alert bracelets, backpacks, notebooks. People are getting very inventive with medical alerts. There's a few things here, a few examples. There are seatbelt covers. There are bracelets, and those that have patients or children that have any kind of a sensory issue, like my child, no way would he wear a bracelet. And I know it's kind of hard to see. There's in the collage sort of picture in the middle, it's a sort of a QR code that goes on a shoe. And my darling boy, I tried that as well. And my son was just hyper focused on the fact that he didn't have that label on both shoes. He needed them on both shoes. So that didn't work. And so parents try to get creative. And the middle one is the kind of the newest thing that I discovered, and that's an actual shoe insert. And there's a plastic like holder on the back that you pull out the shoe insert and you pull out the inside, and it has medical information on it. These are things that people are whether it's convenient or not, I don't know how anybody would know that that was there, but maybe there's a tag on the coat that says, look on my shoe, I don't know. People are getting creative. There's window clings, there's so many things to try to give you a clue as to the medical conditions. And my son, for instance, every single article of clothing that he has his name and phone number stamped on it. Everything. We're talking underwear, we're talking socks, we're talking everything. And everything is stamped with his name on it. So people are getting creative. So that means you kind of have to think outside the box. And I hope it doesn't get more complicated, because you are never going to find some of these things.
Right. And the other thing, we were talking about making sure you look for the backpacks and the notebooks of the kids. And when we talk a little bit about disaster preparedness for kids with special healthcare needs, make sure hopefully the notebook has a picture of the child that has the, is the special needs kid. And you make sure that the backpack and the notebook is the same kid. When you don't have a guardian around and you don't have anything else, you've got to be somewhat of a detective, and you have to make sure you have the correct patient. And one of the things, when I don't have a family member who knows the kid, reading the old chart as best you can, noting reactions to medications. So when we're talking about pain meds for Devin, pain meds for anyone, different people respond in different ways to different pain medications. And so knowing which one works for the child, our sickle cell children children with sickle cell have a lot of different abilities to respond to pain medication. And we'll look up a pain plan for them so that we know that Dilaudid works great, but you have to give Benadryl with it or else they itch. And that morphine doesn't work well, but some other pain med can. And maybe you want to try Toradol instead first. So it's important to kind of think about the patient and how you're dealing with it. Ideally, these kids will come with something that looks like this. And this would be a care plan for a special health care needs child. This is pretty small. I mean, it only has room for 4 medications, but it encompasses the plan of what you want to do. It can be expanded. It also talks about different accommodations for diet or feeding or toiletry. And then special equipment. I don't know how many charts I've dug through to try to find the size of that stupid G-tube, because, you know, when you're replacing a G-tube, if they didn't come in with the G-tube, you've got to get the right size one. And it is hard to find it listed. So now whenever I'm dictating a chart before they go home, I'm putting in the size. And those of you who have dealt with the G-tubes, they have a diameter and they have a length. And so trying to get the right one in is the right idea. Important telephone numbers. I sick my social workers on trying to figure out who has the authority to approve something for a child. It is a complex issue. If they happen to have a care plan, then taking advantage of that is good. The most well thought out ones recently have been the asthma action plans. And those are really helpful. Usually the parents are using them when they're going through the green and yellow level of illness. It helps us too to know if they respond well to budesonide for a nebulizer treatment. And so using the instructions from there and having it all printed out really helps everybody. These are some more emergency forms for school. And as I said, the most important thing is to have someone fill them out and try to keep up to date. I've had some of these forms come in and they've been crossed out and scribbled over because they're changing the medications. It doesn't take much to get a new piece of paper and write one out, but just, you know, trying to clear it with the family. What are they on? What stops them? What did you give? How did you give it? I've had the way a anti-seizure medicine has been given changed 3 different times in the course of evaluating the kid. And only when the parent came in did I know that they had given it buccally. They put the Versed between the lip and the gum. And the initial person who brought him in said, no, they gave it rectally. And somebody else said, no, they gave it as an IM shot. It's like, oh my gosh, you know, what works for them and trying to keep the information straight. All right, Melissa.
Yes. And this always goes back to my full story question. So this was early on, and my son, after he was born, his conditions were diagnosed over the course of years. So you might be in that situation where there is no diagnosis, you don't have one. So I think it's that and you have new equipment that you're learning, and you have the caregivers may just not even know. This is something not even diagnosed. So this is the story, and I think some parents can relate to this. Baby's crying, of course, mom's crying too, because you're kind of helpless, like, what do we do? So my son, one of his very first things that he had was when he was 4 months old, he was woke up just crying and screaming, and nothing could comfort him. And his stomach was literally getting bigger before my eyes, and it was just hard as a rock, and panicked. And I called 911. We got my son to the hospital. Immediate testing showed that he had malrotated intestines, and surgery immediately. So he had surgery. He had feeding issues, so a feeding tube was placed. So now I had to learn the feeding tube. And so new mom, new feeding tube, I don't know everything. And so we're at home about a month in. My son just starts screaming and crying again. And there was nothing I could do to calm him down. Called 911, EMS, and must have gotten somebody who was familiar with feeding tubes. And he just said, hey, did you try venting the feeding tube? And I'm like, oh my gosh, no, I didn't try that. And those of you familiar with feeding tubes are, in particular, the Mickey button is what he had. It has an extension too that you can connect to it. And we connected it and a whole bunch of air came out and the biggest smile on his face. And I'm like, I'm so sorry that I called you for basically gas. and couldn't have been nicer, kinder. And it was just, but like I said before, you're just like, help, just help. And they came and we problem solved and we figured it out. And it was like I'm saying before, you don't have to know the entire picture of the child or every single diagnosis. You just have to problem solve to what is the problem right this minute? What are we trying to solve for right now? And just be that partner with us and to figure this out.
Right. And so you have to be kind of like Cumberbatch. No, you have to be like Sherlock Holmes. You need to be a detective. And those of you who work with pediatrics, that's what you do anyway. You're a detective. You look at their clothes, you look at the body, you look at for anything else. The reason why you look at the clothes is you want to see, does a child have wear on his shoes? If they're here without their parents and the shoes look like they're brand new, it's probably because they're not a ambulatory child. You know, just looking at them. If you look for scars, you see that midline sternal scar. Oh, they've had open heart surgery. You need to be aware of that. You look for G-tubes. I have to confess, I've admitted kids to the hospital and I didn't realize they had a G-tube. Of course, the problem didn't relate to the G-tube, but it was still, I was not paying attention to the right things. And then the other thing you want to do is try to figure out ways of communicating with the child. As Melissa said, you don't ask, you know, how retarded he is. I ask about, well, what works great for communication? Is it better to talk to him, or should I just kind of be calm and allow him to touch me first before I touch him? Many times the family will tell me what they're worried about, but if they're without the caregiver, you kind of go slow. You kind of really take your time. One of the things that we developed through EMSC Minnesota were the communication cards, and we'll show you those. These are the Mayor Johnson symbols that are often used for autistic and can be also used for non-English speaking patients. And they show symbols and diagrams of kids in different way. Yeah, go ahead, Melissa. And it just is a way of communicating. And the autistic children, the children with autism have, can be used to these symbols and can communicate with you.
Yeah, this was something created with the Minnesota EMSC many years ago because children who are nonverbal, children who have autism, what has been very helpful is that they are familiar at a very young age in schools or in therapy to use these Mayor Johnson symbols. And then they are also used they can be used throughout the course of their life with communication devices, electronic devices. So these symbols are somewhat familiar to them. There was two purposes of the symbols. One is to relieve anxiety. So it was just a matter of showing pictures like we're going to the hospital, just so the child can anticipate what's coming next. And this is relieving anxiety. And the other pictures are to choose. So it's choosing, yes, no, hot, cold, those things are where they can actually use communication as well. And what was incredibly cool about this program and this project was that we created this. We got some insight from rural EMS because we don't want to create something that is not helpful. And I'm not an EMS person. I don't know what's helpful. And then some of the stories that we did get back were, I didn't have a child that had autism, but I did have somebody who was non-English speaking. I had somebody with facial trauma that couldn't communicate. And if you can't talk, it's like there was no other tools handy to use. And so they pulled out these cards. I know, and if you contact some of the facility people we're gonna have their contact information at the end, because what was so cool is that this idea got to be popular, and then other states created similar versions of it. some very cool things, and it kind of just spread across the whole US, and it was amazing. Different states have different versions. Some have things that are really specific to the population that they have. So maybe their symbols also have like English and Spanish. It's just been a very cool thing. And I know that we offer these out. And so contacting some of the program managers to see where you can get them is something to think about. It can be a very helpful tool.
Right. And then other tools that will help you with communications, or at least calming the patient, are things like bubbles or flashlights. I mean, you all have a flashlight with you usually. And so kind of using it and showing it that it's not painful, and trying to communicate and get a common ground, a common level. What we're going to do now is have another break for about 5 minutes, and then we'll resume. And then we will be working through disaster preparedness with children with special healthcare needs and red flags. And then we'll be on our way to finish. So save your questions, send them in, and see you in 5. Maybe. So we have about 1.5 minutes before we resume. So 1.5 minutes. So we have another minute before we start back up again. Well, welcome back to the seminar, Caring for Children with Special Healthcare Needs, EMSC, the Heartland segment of the United States. And we're going to resume, and we're going to start up first with some polling questions. So the first polling question is, oops, no, we aren't going to start with a polling question. I thought we were. Well, we're going to start out, this is the way we're going to do is common equipment. Yes, we've got a polling question coming up right after we go over the overview of common equipment. So we're going to talk about ventilators and trachs, pacemakers and defibrillators, VP and VA shunts, feeding tubes, and insulin and baclofen pumps. So this is the polling question. This is kind of our fun polling question. What do you do if a gastrostomy tube falls out? Do you cover the hole? Sorry about that, screwed that up. There we go. Cover the hole, cry and wait for backup, do nothing and transport, find a tube or something and put it in the hole, secure it for transport. So coming up, our next and final question. Okay, you've got about 10 seconds or so, thereabouts. What do you do? Cover up the hole, do nothing, put something in the hole, cry and wait for backup. Okay. So the majority of people said cover up the hole. But if you've got a long transport, the biggest worry is that your hole is going to close over and make it difficult to put a new gastrostomy tube in. So say if we'll show a picture here. So the true answer would be find a tube and put it in the hole and secure it so that you can transport it. So let me close that off and we'll go to the picture. So here, the G-tube there is the one in the center with the balloon. And oftentimes they get pulled out with the balloon intact. And so it can cause a lot of irritation and damage to the gastrostomy site. And it will cause some scarring that will close over the tube. So if it's been out for maybe an hour or less, I think you could just put something over it so that you don't have a lot of acid and food particles coming out and transport the kid in. If it is going to be out for longer than an hour, what can happen, since there was trauma with the tube getting pulled out, it can allow that opening, that ostomy opening, to start to close over and make it really difficult to get the G-tube back in. So that's why if you can put something in it, and things you can put in it would be, you could put the old G-tube back in it and tape it down. You can put a feeding tube in it. You can put a trach tube in it and cut it off so it's shorter. But just especially if you've got a longer than an hour-long transport, help us out and put something in it so you can keep it open. So feeding tubes are usually in the ones like this little baby through his nose. That's a temporary thing. So he's only going to have it in him for maybe 3, 5, 7 months of his life. And then hopefully he's going to start enteral feeding, or they might need to put a tube in someplace else. The J part of the NJ and the J tube is more related to jejunal tubes. So these are tubes that go in either through the nose, so that'd be an NJ, or through the gastrostomy into the jejunal, the second part of the duodenum. And that is because some kids can't handle feeding in a manner that they don't get a lot of reflux. And if you can do a constant drip into the jejunum, you can feed them for a while that way. Those little tubes oftentimes get clogged, and trying to get them open, there's Clog Zapper, which is a special type of enzyme thing that you can put in that will open them up. But also you can try Coca-Cola and different kind of acidic type soft drinks will sometimes open them up. As I said, they fall out, and you can usually get something else in it to keep that open. They can get infected, but it's not very common for them to get infected. When I was telling my daughter about this talk, she was saying, oh, you don't want to put anything in there that's not sterile. But you got to remember, everything that goes into your stomach was once in your mouth and was once in front of you. So actually, just cleaning off the old G tube and putting it in and taping it on is okay. You're not going to have sterile stuff in your stomach anyway. So those are the feeding tubes that we oftentimes see with kids. We'll speak kind of briefly about trach vent patients. The ventilators, some kids are on ventilators. The important thing on ventilators is to try to use whatever setting they're already on, and maybe upping the oxygen. If they aren't doing well on the ventilator, or something's wrong with the ventilator, you can always try hooking up a bag and watching the chest rise to see if that will work. And remember that you can hook up nebulizer treatments through the trach, so you can get them albuterol in that way through their trach ventilator tubing. The biggest worry on trachs are that they oftentimes fall out, and hopefully the family will have another one handy, or you can try putting it back in. I know it always is a scary time to try to put it. If you can't get it in, you can bag, put a small mask across onto the bag valve mask and bag over the trach. You'll have to close the mouth because the air will go out through the mouth, but you can bag that way and get by for a little while. What you can do is make sure you suction if it doesn't working very well, and then if they have the kit to replace it, and that's what this thing is here, is a replacement trach set, you can replace it. Make sure you secure it well when you replace it, because if you're transporting and you don't have it tied in well, you can end up losing the trach. On kids who are on vents, remember DOPE. This is a mnemonic to help you troubleshoot problems when you're not getting the oxygenation from it. D is for a displaced tube, a damaged tube, or a dislodged tube. I had a kid with a trach who came in, she was nonverbal, and they said she's having an allergic reaction. And her face was all swollen up, and her neck was all swollen up, and it sure looked like an allergic reaction. And we gave her epi, and she didn't improve very well. And we changed her trach, and it didn't improve, and we took x-rays. Finally, things were stable enough. I transported the child to the ICU, and then I got a call from the ICU doc later saying, did you realize that the trach was in a blind pouch in the neck, and that's why the face was blowing up and why the neck was blowing up, and there was enough pressure that it was actually going through the blind pouch back into the trach so that the kid was still ventilating. But he said he got it in the right spot, and just wanted to tell you. And it was like, oh, geez. But, you do your best you can, and the kid was stable enough to get up to the ICU. Oh, my lights are going out again. Just being aware of that. Obstructed trachs can sometimes be caused by mucus. Yep, Chelsea fixed it. Secretions. Then pulmonary conditions can make you have a poor outcome with a trach vent, and that would be things like asthma or pneumonia. And finally, equipment failure. The biggest equipment failure is someone standing on the oxygen tubing. And this is something that happens in all times. And it's just, you know, just looking around and being aware, or having the oxygen tubing hooked into the air spigot instead of the oxygen spigot. Just check it out and, you know, take your time. You have time. You just got to find the right thing. Other equipment, pacemakers. Be aware when you see an EKG spike that it might be a pacemaker, and also be aware if you're going to try, if you're thinking about defibrillating a patient, that you may already have a defibrillator there. Just look for the signs and be aware. Ventricular peritoneal shunts. This is for kids who have hydrocephalus. The diagram up above shows the shunt. It goes into the ventricular system of the brain, and then there's usually a one-way valve at the skin, just subcutaneously, and then it tracks subcutaneously down the neck and into the abdomen. They also have VA shunts, but they're not very popular nowadays. That means that they went into the atrium of the heart. Two of our big problems with shunts are infections or obstructions. Infections is the same thing as a meningitis. And so if you have a kid who has a shunt, who has fever, headache, vomiting, it could be meningitis from the shunt, that, you know, they've got a piece of equipment in their system, so it's always at risk of infection. Obstruction is the second thing that happens with them, and that usually is the same thing as if they were having increased intracranial pressure. So they're headachy, they're fussy, they're vomiting. Parents come in with their children who have VP shunts, and they say, this is the same way he acted when he had a shunt malfunction. These are surgical emergencies, and the important thing, things that you can do with that is, one is simple, is just keep the head of the bed up at about 30 degrees. That will help reduce the pressure, and then get them to the hospital. Pumps. These are the pumps that we would use primarily for medications like insulin or baclofen. Insulin pumps are incredible these days. We have insulin pumps that measure glucose, as well as figure out the resting insulin amount that they should be given. Just like with any piece of equipment, there are malfunction problems with them. Two of the biggest ones are that they run out of medicine, or that the batteries run out of energy. I had a patient transferred down because the pump said that there was air in the line, and it was actually out of medicine. And they didn't realize they had flushed it, and they were flushing it with saline, and the child went without insulin for about 6 hours. Child did well, but it was a situation where it just said that there was air in the line. It didn't say that it was out of medicine. So be aware of those things. Sometimes the easiest thing is to just not have the pump running and give the patient sub-Q or IM insulin if they need it. Baclofen shunts are primarily for kids who are very spastic with CP, and it reduces the spasticity. Those things don't always need to be running. So it's helpful because they have a constant supply of baclofen, but if it's interrupted, it's not as life-threatening as insulin pumps being malfunctioning. All right, so Melissa, I think you're up next again.
Yes, and this is, I'm probably gonna sound like an infomercial, but it's like, wait, but there's more. Like there isn't sort of enough that we've covered here. There's other considerations to keep sort of in the back of your mind as something that happened to us because we are taking such phenomenal care with the help of many people that do have special health care needs as a child, then become adults. And this is the stage that my child is in. And so he commonly gets pneumonia. And we have a standalone emergency room close. And so and they're familiar with him. So we went there and figured we'll get a chest x-ray to confirm the pneumonia. And then we sort of have our plan with nebs and whatnot to go further. But in this instance, got to the hospital. We had a chest x-ray, not pneumonia. He had a large pericardial effusion. And he did have cardiac surgery as a baby, but relatively stable. And so my immediate thing to say was, okay, you know, his specialist, his cardiologist, is at the pediatric hospital. And so then that's the plan. We have to get him there because he has to get the fluid drained. And that's the pericardial effusion is fluid around the heart. So what happened was the physician came back and said, pediatric hospital won't accept transfer because of the age. And my mind just blew up. And I said, no, his cardiologist is there. At our last appointment, I was told that we didn't need to see an adult cardiologist yet, that we would hold off and revisit it. But the problem is that was a decision made by a physician, and the hospital has different rules and different protocols that they have to follow. There are age out rules that existed, and now we are in an emergency. So this came down to where does the child go? The child's known at one hospital. That's where he gets the majority of his care. Now, what do we do? The only thing to do is we had to get that fluid removed. So he did go to an adult hospital that had not one single medical record. And of course, this is always going to happen. It's going to be on a Sunday. And so, you know, limited medical record staff to be able to transfer records. And even though I said, I know this is an emergency, there's a few things you have to be aware of. His anatomy is not correct. Like there's things that places they shouldn't be, you know, I'm just like trying to say this is the bad idea. Like, I want you to know these things before going in. And they said, you know, they were very confident. It's a very sort of, you know, it's a simple procedure. We go in with the needle and we pull out all the fluid. And we do it by ultrasound. We're going to be fine. I'm like, okay, we're going to be fine. A long time passed and he was in the surgery and I was very nervous, and they came out and said, we didn't remove any fluid and his liver was obstructing the, whatever it was, we couldn't remove any fluid. And my son got back to his room and we were changing his clothes and he had 14 puncture wounds across his whole chest. And I'm like, oh my gosh, you know, these pediatric to adult transfers that aren't happening on the outpatient side not in an emergency, but in a coordinated way. This is going to happen and things are going to fall through the cracks. And so this is something that you're going to run into. And it's what can you do to help facilitate that? Is there anything that you can do to help with medical records, help with anything? Even just orienting in the ambulance, which was what our EMS person did, because the pediatric hospital and an adult hospital are two very different things. So I had a ton of questions, like, can I come with him? Like before I used to be able to go right into an induction room before when they put him out, and they could answer the best they could. But those are another consideration. So then there's if you want to go to the next slide. So, of course, there's more. There's a child with special healthcare needs, but what if that's not the person that called 911 that you're responding to? So with us, it was my son home alone, or I was home alone with my son. We do have home care, but there's a home care shortage. And there was a home care shortage 20 years ago as it is today. So we were supposed to have 24-hour care. We ended up basically with 8 hours every other night. And then when you're in these situations, you're operating in a survival mode. Devin's dad, being that I couldn't work, and if you remember that picture a long time ago in the beginning of the presentation, it was, you know, I had Devin at 18 years old. And so his dad was 19, and this happened when Devin was about 2 years old. So dad's working 3 jobs to pay, because we have minimum wage jobs. And so I had to stay home because of the home care shortage. So it's just me and Devin. And at this point, Devin was at his most critical. So he was on respiratory equipment. He was on feeding pumps. We had a lot going on. So if you want to click to the next thing. So that's when good old me decides that I should have SVT. So, and as a mom, I don't know how, if anyone, maybe you can understand this, but when you have a child, especially a child that has a lot of needs, you put yourself in, no matter how many times people tell you to put yourself first and to take care of yourself, it just never like permeates your brain for some reason. I knew I had a fast heart rate and I didn't know why. And I did hook myself up to my son's pulse oximeter. I'm like, 180, that can't be normal. But of course, mom lets it go for another hour because I thought, well, maybe if I can, this was about 1 o'clock in the afternoon, but I thought maybe if I could go to 11 o'clock at night when my overnight nurse came, we'll be fine. Because my first concern is my son. And I can't call a neighbor. I can't, there's no easy answer here. Call 911. They come in and they saw that I had a child that was on equipment. They immediately hooked me up. And the only thing that was very interesting is I was doing a tube feeding in this process. So they had me hooked up, but I was holding my son's feeding tube syringe because we're not going to miss a feeding over this. So you can go to the next, click next. And I said, I can't leave my son, so I'm not going. I'm not going to the emergency room. Now think if you were an EMS in this situation, that's like, what would you do? And I'm sure transport refusals are like, okay, there's some paperwork and they don't want to be transported. But the situation was not that I didn't realize that I need medical treatment and I needed attention. My blood pressure was severely low. And they said, someone just said, we're bringing him with. And they said, does he have a go bag? And I'm like, he sure does. So we got the go bag. And this EMS staff person was the point of contact for my son. He never left my son, and my son trusted him and went with him, but he never left him. He went to the ambulance with us. This EMS person just stayed with him because that was the person, my son, it wasn't like various people saying, you take him now, you take him now. He stayed with him. And so then, and dad was able to meet us there later because I wouldn't let him do a cardioversion until I knew dad was cared for. I was a problem patient, so we're not going to use me as an example. So, so there's other considerations too. So we can go to the next slide.
Yeah, your stories are great. Anyway, so we're going to switch gears slightly. We're going to talk about children with special healthcare needs during disasters. And it really depends on the type of disaster how it's going to impact a child with special healthcare needs. For example, a child who is deaf is not going to hear alarms and sirens and explosions and may not know to leave and move until they see other people moving. A child who is not independently mobile may not be able to flee a situation. So it all depends on the type of special needs. A lot of these children and young adults have respiratory problems, and so they're very sensitive to toxins. A lot cannot communicate and can't tell you what's going on. So that it is a total combination of things that may go on. And then also they have a wide variety of abilities to respond to the different stress. They may run away, they may run too. It is all ranges of the gamut. So for example, during the pandemic that we're having right now, the children with special healthcare needs, very few of them can tolerate a mask. And so how do you tell them to keep the mask on? And then how do you protect them from getting sick? They don't know how to wash their hands well, perhaps. And many are immune suppressed. So again, it depends on the disaster. During power outages, the kids who are dependent on power with ventilators or BiPAP or pumps or IVs, they may not be able to handle it. And so I know with Katrina and the hurricanes in the South, A lot of those children automatically go into the hospitals where they have generators, or they get transported someplace where there is a generator. Medications need to be refrigerated, especially insulin. There was a big problem with insulin with Katrina and the hurricanes. And so trying to keep track of that. And also things like special severe weather situations. In the Midwest here, we have lots and lots of tornadoes. So with the tornado season, severe weather can cut off with power supply. And how do you handle severe weather that's coming at you? I think, Melissa, you have another episode of this going forward.
Yes, because you're not protected, even though you have challenges in the day-to-day life of caring for children that have special healthcare needs. You're not immune from the environmental factors that can come. So of course, you know, why not get your house destroyed by a tornado, which of course happened to us. So in this world that you live in this scenario, when you have any type of warning for severe weather, and in Minnesota it's the tornadoes, the ice storms, the whatever, and you have a child that's on equipment that needs power, you start ramping up your batteries and you start loading up things to go to the basement, and you're ready just at the hint that there's possible severe weather coming. Thank goodness, so we were ready, and so it was clear it was coming into our area, and so the tornado. So went downstairs, unfinished basement, but Devin's in his stroller. We're just hunkering down. Water starts coming down the walls. Devin thought that was hilarious. So good entertainment. But I go upstairs, and yes, you know, all of our windows were shattered. The siding was down. I mean, it was horrible. And we had our batteries, and so that was good. So we had that going for us. But then the battery started to lose power. So then you move to a vehicle and you run the vehicle, and that's your power. But then yes, you go to an emergency room. Is there an emergency? No. Do you need power? Yes. So we did go to emergency room just for the pure sake of getting power. And there's a form. You're not expected to be able to read it. It's but if there's medical emergency forms that you can fill out with local electric companies, and this will alert them that you have life-saving medical equipment in the home, and so you are priority to get your electric restored. I know ours locally in Minnesota, this is a doctor-signed form, but this is a proactive approach before anything bad happens.
Right. And so we're going to talk a little bit about another situation that could be related to a disaster. So if something similar to an emergency took place. So go ahead, Melissa.
Yes. So now that my son is 24, he's acclimating to a group home, and he has 4 roommates, four other young men that live with him. They all happen to have severe autism. They're all nonverbal, and they're all young adults. And so this is a group home outing. Back when you were able to do that. Now not because of COVID. You know, it's just a trip to the grocery store in the van. So they're all in the van, and there's a tiny fender bender just trying to park. Just a little scrape on the car. Protocol for the group home is you got to call police and have a report. So in this instance, we can take a situation that's relatively minor and make it a whole lot worse. So not necessarily knowing all the details, if the police or anyone was even aware of the people that were in the vehicle. They're all sitting in the vehicle, and of course sirens come. A lot of the young men have sensitivity to sound. And not so uncommon with people that do have autism is they run when they have anxiety. So the door flies open of the van, all 4 of them just take off. Now they're running throughout the parking lot. Thank goodness it was all, you know, taken care of. They were fine. They were all calmed down. They, you know, they got them into safe, but it was sort of a, how can we make sure that we're not going to take something that's like a level 1 and really bump that up to a 10? So it's just having that knowledge that, okay, how do we approach this? And whether they had advanced warning or not, I don't know, but did happen to call a problem. So if you have any kind of pre-warning in this, then you know that we don't need to make a situation worse than it already is.
So now we're in our last segment, and we're going to talk about red flags. And some of these things we've touched on a little bit before, but mainly we're going to talk about things that, that you don't want to miss. And probably the biggest thing is looking at the normal vital signs and level of consciousness and cap refill. If you can't explain it, then there's something wrong, then make sure you have someone check it over. Compare it with old records. And if you have a nonverbal patient, think of things that would cause you to be uncomfortable. Are they hungry? Are they thirsty? Are they too cold or too hot? Are they having a urinary tract infection? A lot of the kids who are wheelchair bound have osteoporosis and can easily get fractures. And just in the normal movement from bed to chair and chair to bed, they can get fractures. And so getting x-rays is a wise thing. And it's not that much cost, and it doesn't also hurt anything. And then the other thing is be aware of possibility of abuse, neglect. And so when you're talking to the caregivers, if they're concerned about something, investigate. Use the care plans. And as I said, consider non-accidental injuries, and that's child abuse. We are all mandated reporters. And even, well, most of you are. If it's a family advocate, you're probably not a mandated reporter, but if you're a healthcare provider, you are. And so being aware for non-accidental injuries for children and vulnerable adults. The things that perk up my ears are injuries that don't fit the story that they're telling you. They're saying that the kid fell down the stairs, but he's got bruises on his abdomen. How could did he hit the, you know, what did he hit on the way? Or a baby that has bruises and is not mobile, is not crawling yet. There could be a reason for that, that is not because of them getting into a situation. Injuries that are in places that don't usually get hit, like as I said, the back of their back or their stomach. Kids get hit on the shins. They take it on the forehead. They take it on the chin, but they don't usually get hit in their thighs. And look for symptoms that can't be explained, hematuria or a weird rash. Look for patterns of injuries and chronic injuries. Okay, Melissa?
Yes, so this is a difficult one to talk about, but I want there to be an understanding, especially with this group. So my son, as I said, was in a group home, and this was very recently. Because of quarantine, I used to visit 2 to 3 times a week. I've only seen him twice. And this particular is twice since March. And this particular incident is, I sort of crashed an appointment. So he had an appointment with and he was actually, this was one of the appointments he was able to go to. A lot of his medical needs have been postponed, which is also unfortunate. But he did have to have an orthopedic appointment, and I did go to the hospital and was with him at the appointment, and lifted up his shirt and saw this massive bruise. So the point is that he isn't able to talk. He cannot call me. He cannot report or say he's being harmed in any way. And I know this is a tricky subject, and it's very uncomfortable. And when we think of child abuse, or we think of child neglect or anything, the issue always comes as like, I don't want to stir up trouble. I don't want to blame a parent or a family for anything. But if you think outside the box here for a second, especially children with special health care needs. There are so many people involved. There's school, there's home care, there are, of course, parents, there is, like in this instance, a group home, and it's the child that you have to protect. And I say that because it is, and it has to be documented. If it is maybe something related to the parent and it's documented, does that mean anything absolutely horrible? Not always. Is it a sign that the family needs help? They need respite of some kind? Or is it the child is injuring themselves, and that's an issue that needs to be addressed? Is it a caretaker? Is it a school? Is it anything? The thing is that they, especially vulnerable adults, especially children, need a voice and need, at least in this situation, and we did an x-ray, of course, and it was okay, but I said, you have to put it in the note. Put it in the note. Because that's the thing, if I needed to file a vulnerable adult report or anything, it's documentation. And if it is the family, maybe it's a cry for help, that they need respite. This is an incredibly hard thing to manage on an everyday basis. And if you think of home care, if you think of anything, I mean, it's never okay to harm a child, but maybe it's that they have other children and that this child just fell because they weren't being supervised. Maybe it's not an intentional thing, but just a matter of not being able to have full supervision because you have so many other things going on. Just look beyond that and speak up for these kids no matter what the situation is, because this can't happen again. I mean, I'm a mom coming at you with this, but I'm like, this won't happen again. It won't happen to my son again. It's not gonna happen to another kid again. And that's what we need to be aware of. So, thank you.
So, in conclusion, these were our objectives. We wanted to improve your knowledge and understanding when interacting with children and youth with special healthcare needs, and kind of talk about the types and the range. I mean, this is an enormous volume of kids. I think one of the questions on the chat said, does one medication equal a child with special healthcare needs? If it's one like insulin, probably, but if it's ibuprofen, maybe not. But yeah, there's a wide variety of these kids who need help, and the categories are astounding. It was very difficult to try to narrow it down and make it compartmentalized. Figure out the strategies for finding the real problem with the child, or how you can help them interact with the family and guardian, and be a detective. Look for clues, solve the problem. It can be a lot of fun. And then you need to know how to handle some of the equipment, but not all, but make sure you take advantage of the parents and the guardians on this. So they come in all sizes. They look different or they look just like us, but you can do it. You can relax and treat them. All you need to do is kind of spend your time and talk and listen. So these are the resources. Melissa, I don't know if you want to come on board too. This EMSC Improvement and Innovation Center is our EMSC major website center. And there are resources throughout that for EMS and special healthcare needs. And then the AAP has a whole section on special healthcare needs as well as disaster planning. And a lot of those forms that we showed can be obtained through that. The ready.gov is actually a real good one for all families. It talks about go bags, it talks about plans, family plans, and then Melissa, you want to talk about Family Voices and Autism Speaks? You're muted.
Oh, I was waiting for that to happen. Happened at the end. Almost made it. Yes, Family Voices, some Autism Speaks. There are resources. This is a very tiny list. There are so many resources out there, and we just couldn't list them all. But if you research it and you look out there and you are dedicated to finding other resources, there are several resources. but probably one of the most important things is in your own community. And how can you partner with your pediatric hospitals or your pediatric providers? How can you do anything to plan for getting to know the children with special needs in your area? Anything like that to sort of build on this partnership so these aren't so scary and these aren't so unexpected for you. So I think that we are on to questions.
Yeah, we're going to have the managers are going to deal with the questions. I wanted to real quickly click to our thank you picture because there's Devin giving us a thumbs up, and our ways of getting a hold of us. And feel free to email us, etc. And one quick plea for Minnesota providers: we are getting together a group of people to work on special healthcare needs in Minnesota. So you can get a hold of us or Chelsea, our EMS manager. And here are the EMS contact information for all the managers for the HEC region, the Heartland region. So managers, how do you want to go about doing this to talk for questions for the next 15 minutes or so?
Hi, Dr. Kocken. So I will be going through the questions that people have been putting into the Q&A box, and there have been some really good ones. And I'll just kind of be reading those off, and we can kind of get as many answered as we can in the time we have left.
Yes.
So if you guys are ready to go ahead and start, I've got a few lined up here.
Yeah, real quick. So Brittany, what we will do also is the ones that aren't answered, we may answer in a text and post it at each of the sites or so.
Absolutely, that sounds great.
Yep.
Okay, so this first one is a little bit more on the clinical side. It goes back to when you were discussing children, especially with cardiac malformations, where their resting oxygen might hang out, in the 80s for their sats. There have been a couple questions asking, would you recommend giving them low dose oxygen, or if that is where they normally rest, just kind of like as Melissa said, you like to say, handling the problem at hand that's right in front of you.
Right, yeah, so if their resting oxygen is like 85 and they're at 79, 80, the idea is to get it up to their standard resting oxygen level. And so low dose oxygen to kind of titrate up is the wise thing to do. We are finding, especially even with adults and such, that high dose oxygen at times can be more of a detriment than a help. And so getting someone up to where they usually live is probably the best thing. Kids do not have that that oxygen drive mechanism that adults, if you give them too much oxygen, they won't keep breathing. Kids usually will keep breathing. So you won't be as much trouble as you do with like a COPD, or that you give too much oxygen and they quit breathing on you. They just won't do any good if you give them more oxygen than what they can usually handle. Okay.
All right, thank you. And then we have another one here. Are there any studies or data that indicate the types of children and youth with special healthcare needs patients who have poor outcomes after an EMS counter? Maybe thinking too like urban versus rural, and then maybe where should EMS invest their education time in regards to these, high risk, low frequency areas?
Yeah, so in so EMSC and the PCARN network has been doing some studies on distance to pediatric hospitals. And there, it was just in the American Academy of Peds Pediatrics Journal on talking about the advantages of living in urban areas versus rural areas, and they it is more of a percentage as opposed to a specific problem. So it does have problems when you do not have access to pediatric ICUs. So I would suggest if you want to go to the AAP, you can find information from that. But yeah, kids with special needs usually do better if they are in urban as opposed to rural areas, just because it is easier to get emergently to a tertiary care pediatric area.
All right. This next one here, Melissa, this touches on kind of what you'd spoken to kind of in reference to, your son's experience with, not receiving pain medication when he had fractured his arm. So if your patient isn't able to respond to what is your pain level on a scale of 1 to 10, what would be some good ways that first responders could, ask or assess that pain level, when the parent's not there? Because you obviously know when your child's in pain, but, the EMTs aren't going to be as familiar with their, cues?
Yeah, that's a great question, because they're just starting to kind of put some data out there that the pain scales versus children that have any developmental disability or autism, and what the validity is there. So I think that is currently being studied. So that's going to be interesting to see what happens. And I'm always going to go back to the talking with the family. Call them. I will tell you how Devin responds to pain in those situations, or you know, like, does he look like he's literally, he won't blink is kind of the thing. And so that just a communication link to describe the situation and get feedback that way. I don't know the validity of a pain scale. Wouldn't have been helpful in my son's situation. It was just a matter of seeing an injury and kind of making your best judgment. But I always, if you can contact a family member and get more information about the reactions to pain and what the child is typically responding to. So I know that's not the best answer, but yeah, that's what I got.
And then we have one here. You know, this person had a kind of a personal story, but essentially comes up to, how would you address an adult who has, the mentality of a child? Like trying to communicate with them. She said, for example, this person, they don't handle needing medication. Well, they just kind of want to nurse that injury themselves, but they have some mental disabilities that are undiagnosed. But again, adult in age. So kind of any tips or tricks for interacting with those individuals?
Yeah, so it'd be the same. So that's where my son is coming into play now that he's getting in older. And we put how I like to explain it is he's basically a developmental level of 2 or 3, but he has 24 years of experience. So it's kind of hard to adjust, but it's those communication techniques, those cards would come in handy. But try everything that's in your wheelhouse. Mm-hmm. Try different pictures are always good. Examples are always good. My son, if you show, like, I'm going to put an IV here and you show it on your own arm, and it's kind of a see and do so they can anticipate what you're going to do, and just different things. We did have, so my son, it's a lot more comfortable doing things, especially painful things like IVs and whatnot, if he knows it's coming. And he also, if he sees you, so we often pretend, sometimes the EMT or the emergency room will pretend like they're giving me an IV, and then that gets my son in the right, like, okay, I can do that too. So those things, it's using nonverbal communication, it's any of those.
Yeah, and the other thing that we find is using as best you can distraction or numbing medicine. So if you can get them to put the numbing medicine on the body before you try your IV. And again, as Melissa said, showing a, like if you're going to use a J-tip or something like that that makes a loud noise, doing a fake one so that so they know it's coming and that type of thing. I still think Frozen was built for pediatric ER and for young adult distraction, because every kid, the minute you put on Frozen, they're like watching it and you can almost do anything to them. But distraction, if you can find something that they like to watch or do and distract them and help them out that way. But yeah, the young adult is big and strong, and it's a problem at times.
Right. And this one kind of references, it says, it's been mentioned that some children have, disabilities or conditions where their organs might be in a spot that's not quite where it would be positioned on a normal child. Could that interfere with CPR? And then, basically, how would you know or go about that? Because, for some children, you're not going to know externally looking at them. Right. So,
yeah, so usually the CPR part isn't too much. There go my lights again. But perhaps intubating might be a problem, especially on kids with facial malformations and such. And so with there we go, thank you. So with the intubation business, always having, a couple tubes smaller and handy so that you go down there and you go, oh my gosh, I don't know where I'm going. you know, going a smaller size tube. The CPR, the compressions shouldn't be a problem. You're just going to still be pushing hard and long. Yes, some chests may not be, may have some osteoporosis, but that's a little concern when you need to get circulation. And as I said, the airway is probably the biggest thing on the airways. Like we've got the Pierre Robin kids with the short jaws, getting smaller tubes, and then using the video, if you can, the video intubation laryngoscopes can help a lot. So it makes it hard, but oftentimes you can get by bagging if you do a lot of jaw thrust and kind of position things and get help, someone to hold the jaw, someone to do the bagging. So so fall back on what you're used to doing. Don't try, you know, oh, I only intubate a kid every 3 years. So don't intubate this kid, bag them. Try to get them to bag, increase the oxygen, you know, get positioning, get someone to help you hold. It's the whole idea is to work on your strengths, not on your, oh, I think I can do this. Same thing with IVs. If you really need an IV, then you might have to do an interosseous. But if the kid is running around and you think you need the IV, you probably don't need the IV because the kid's running around. So, you know, think, use your brain, think of what's necessary.
And I think we've got time for a couple more here. This one will probably be a little bit quicker. You know, kind of when you talked about, you know, 20% of children, you know, being part of that, you know, special healthcare needs, they want to know, does that include those who are taking medication for ADHD? And the kind of like your definition for this.
According to the definition for, when we looked it up for our talk, yes, those kids are special needs kids. It sure expands the volume. And so I guess I need to go back and look and see when the 20% was chosen, because it seems almost, at least in my ER, it seems like almost every child is on a ADHD medication, Ritalin of some sort. And so yes, I don't know the true answer to the percentage of kids who are on medications. As I said, single medication could also mean EpiPen for bee stings, and that expands your volume of patients immensely as well.
Yeah. And then last one, and I think this one will be really helpful just since we're kind of seeing this new age of, you know, technology and telemedicine. Do you know of any, you know, smartphone apps or resources that can be used, especially in helping communicate with children who might have, you know, might be nonverbal or have difficulties communicating? Is that something either of you have come across in your experience?
Not me.
So maybe something to be invented then.
Yes, yes. And I'm sure there are some out there. I mean, yeah, we were just talking, a buddy of mine and I were talking about, well, there surely should be an app for ultrasound on our smartphones that we could be able to use. So, but yeah, there probably is some out there for different things. We just aren't as knowledgeable.
I think that is, to bring up the whole telehealth issue also in this children with special needs is very tricky, especially if you're dealing with a child who can't communicate. And so, like in my son's situation, I can't be with him at the group home. And so a telehealth appointment, you have the patient in one area and you have the medical decision maker in another. And so that has complicated things beyond belief. And now things are coming to light that are resources that I wasn't aware of. And those are, you know, you can bring in a third party. There's things like that. There's also technology out there that I know is starting to be used at our children's hospital, where it's not just telehealth equipment, it's these remote monitoring equipment that have stethoscopes, they have all sorts of different things. So I bet there is something out there. I don't know about them, but now I want to know about them.
Alrighty. Well, it looks like we have hit 9:30. So thank you both of you for sharing with us. I know the comments have been fantastic. It sounds like everyone's really learned a lot. I know I have sitting here listening to both of you. So just thank you for sharing. And to everyone who's attended tonight, thank you for listening in. We hope you've learned. Evaluations, you should get the option either after the session concludes or by email. So just go ahead and complete that when you get the chance. And then your state EMSC program coordinator will make sure you get your certificates. But you know, our contact information is up here, so please go ahead and reach out to us if you run into any questions or any issues. But again, thank you to all of you and have a great night.
Thank you.